Thank you for that kind introduction, and good morning, everyone. I'm very happy to be here, and a special thanks to the organizers, one of my dear friends, one of the organizers, for putting this on and doing such a great job at organizing an innovative and fascinating conference. I appreciate the opportunity to talk to you all about something that's very near and dear to me, bringing point-of-care ultrasound into the NICU. So to start with the case. This is a real case. This is a case that I had in fellowship close to a decade ago that was somewhat transformative to my career and also hopefully will serve as a great jumping off point to have this discussion with you all today. So this is a 26-week gestation infant delivered via vaginal delivery, preterm labor. Baby was on CPAP, low oxygen requirements, was tolerating feed advance, pretty typical for us in the NICU. On day 7, the baby had a spontaneous intestinal perforation, a peritoneal drain was placed, had an echo that overall was unremarkable. There's no PDA, the function looks great. There's no significant pulmonary hypertension. A PIC was placed so that the baby could receive parenteral nutrition while the baby was in PO. And up until day 13, he was just growing and hanging out with his family with his little sublux knees and hitting himself in the face with his feet, bringing joy and laughter to everyone that got to know him and his family. But unfortunately, on day 13 at night, he coded and he died. And as these things do tend to happen at night, the team that was on there was not his primary team, but they did everything that anyone from his primary team could ask for. They were called to the bedside for pulseless electrical activity. They immediately intubated him. Even though this was a NICU, they converted to PALS when things weren't getting better. They went through all the H's and the T's of PALS. They did a 30-minute code for this infant. They even checked the PIC. They withdrew blood from the PIC. They forcefully flushed through the PIC. Everything seemed to work well. They got a chest x-ray. There was no pneumothorax, no pleural effusion, no cardiomegaly. ET tube, yes, was a little bit deep, but it was in. The PIC looked a little bit deep, but it was okay, and it was working. And unfortunately, despite all of their efforts, they were not able to save this baby. And it wasn't until the autopsy that we realized what had actually happened. So this baby died from cardiac tamponade. And it wasn't found until the autopsy. So I want to draw your attention to the picture on the left. You see that globular white structure? That is the pericardial sac, filled with just 8 mLs of TPN and lipid. All it took, based on the rate, was 2 hours from the time when the PIC left the right atrial appendage, perforated the heart, and poured fluid into the pericardial sac. What you can see is the venous congestion of the liver, the venous congestion of the lungs, the paucity of blood flow in the intercostal muscle, and the paucity of blood flow in the coronary artery. And what was the hardest for me is that I consented this family to the PIC, and the parents, very educated, very kind, came to me the next day and they said, I don't understand. You told us this could happen. You told us that you would do everything that you could if it did happen to save him. So how come you didn't know that this was the cause? How come you didn't do the one thing that could have saved our baby? And he wasn't wrong. We did not do the one thing that could have saved this child. And while I say that this case is very transformative to me, it was one of 3 cases in the Boston area at that time. 3 babies and 3 separate units that had all acutely died. And all of them, we thought, died from something else. And it wasn't until the autopsy that we realized that they died from something that we could have intervened on. And it got me thinking, how many other babies have died from this, but we don't get an autopsy? I started looking in the literature. It is reported from the 1980s about doing pericardiocentesis. It's reported in the 1990s about doing ultrasound guided detection and pericardiocentesis. So how is it possible in 2015 that we're not doing this? And I want to take a moment while we go through this talk and have you guys think, could point of care ultrasound in the hands of the team that night, could it have saved this child? By the end of this talk, everyone in the room is going to know why neonatologists need to have this skill. You are going to be able to outline to others that there are guidelines, that there are consensus statements. You're going to be educated on where to find them and what they say. And for food for thought, we're going to talk about different applications of how neonatal POCUS has changed my management, my care in real cases. So why should neonatologists learn POCUS? Why not just get a formal radiology study? This is the common thing that I have heard over the past decade. Well, it's not a replacement for a formal radiologic study, but it is something that is rapidly available in the NICU. And yes, I agree. Why should we learn this? Why not just call cardiology? Why not just call radiology? The reality, yes, we have those resources in some of the big ivory towers. This baby died in one of the big ivory towers. We didn't call radiology. We didn't call cardiology. And more often than not, when I'm in a code, we're not calling these people to come to the bedside to bring these modalities. What we're doing is looking at a stethoscope, doing a transilluminator, trying to listen, but not using readily available tools that we can just bring to the bedside. So POCUS is portable. Some of my colleagues are in the room today. They know that our POCUS machine is called Polly, for Polly POCUS, obviously. She has to be named. She's very important to me. And we have gotten used to now in a code that our nurses will go and run and get Polly at the same time they run and get the crash cart. That just highlights how portable this is. And now that I've been doing workshops and talking to people around the country about this and using adult standardized patients, it is shocking to me that the neonates are the last adapters to this. It is so much easier for us to do an ultrasound on a baby than on an adult. The body habitus is different. Their bones are basically translucent. Everyone is scared to transport a baby. How often have you guys had in the NICU a sick baby on the jet and radiology wants a study or surgery wants a study and nobody knows how to get the baby down to the radiology suite? Radiology doesn't want the baby down there. We don't want to take the baby off the jet. So what do? How come adults that are easily transported, difficult to see with ultrasound, how come it is their standard of care and not ours? And it's not just me talking about the benefits. I looked up last night in PubMed. I do this every once in a while for fun and try to see what data has come out of hot topics that I enjoy. And when I typed in neonate and POCUS, as you can see, we are still in a rapid incline of literature. But I want to draw your attention to the fact that there were studies in the 70s about this. Anesthesiology was doing ultrasound in neonates and writing about it. And then for some reason, from 1980 to what felt like 2010, it just went away. But times are changing. So in 2020, we had the first guidelines that came out. These were the European consensus guidelines. They came out with not just, hey, we should do this, let me tell you this story, but they came out with the quality of evidence for each application, how we can use this, what does the data show, where is the data lacking, where do we go next? 2022, the American Academy of Pediatrics has now said, let's do this. We should have point-of-care ultrasound in every NICU. We should do it for diagnostic and procedural purposes. Here is this wonderful article that will tell you what to do. Then in 2023, the same group with the European consensus guidelines came out and said, okay, we understand that there's some hesitation in using point-of-care ultrasound routinely, but is there any hesitation in using it in a dying baby? Are we really worried about replacing formal studies when a baby is dying in front of us? And the answer is no. And so they came up with guidelines, the quality of evidence for those guidelines, and an actual step-by-step protocol that we are teaching you in the workshop, if you guys have been to them, of how to assess the crashing baby. And it's not just pediatric governing bodies that are supporting this. The American Society of Echo in the past year has published not one, but 2 consensus statements supporting and advocating for the use of cardiac POCUS in critically ill neonates and in pediatric patients. So now the guidelines are there. Now the governing bodies are saying do it. Great, how do we actually do it? So in order to talk about the why, I want to highlight some really exciting cases for me. Now, I can't tell you every single application that I use for point-of-care ultrasound or highlight all of the literature that's out there, but what I want to do is do a little bit of a teaser to say, wouldn't you guys like to have this in your NICU? Don't you think that it would have been great to have this when you have these patients? Because I know I'm not alone. I know that everyone in this room has had patients just like this, that they have thought, what else can I do? So POCUS can rapidly diagnose a pneumothorax. That is the number one thing that Poly, again, POCUS, we name our machines, that Poly is used for. When a baby acutely decompensates, some people will go grab Poly, some people will grab a transilluminator. I was trained with a transilluminator. When I talk to my husband who does adult radiology, he still thinks that's crazy, that we just light up babies to determine whether or not they have a pneumothorax. And in my unit, we now are resuscitating tiny babies, 22 weeks. And when you use a transilluminator on them, their entire body lights up. Super unhelpful. We also keep babies in the NICU until they're ready to go home, which means that some babies celebrate their first birthday in the NICU. When you try to transilluminate them, you can't see anything. The ultrasound, though, doesn't have those challenges. And it's quick, and it's easy, and there's data to show that you can go to a 2-hour course looking at lung ultrasound only, and you can go back and successfully diagnose normal lung, pleural effusion, and pneumothorax. You can quickly do this and rule these things in or out in between chest compressions. So what you're looking for are B-lines. For those that were in the workshop, if you see a B-line, those are those vertical lines. They're white, they represent fluid or scarring. Thankfully for us, pretty much all of our babies have fluid or scarring, and so if you see a B-line, you know that the visceral and the parietal pleura don't have air in between them, because air is the enemy of ultrasound. If you see lung sliding back and forth with respirations, you know that there is not air between the visceral and the parietal pleura. The picture all the way to the right demonstrates what a pneumothorax looks like when looking at motion mode. And again, I know I'm throwing out a lot of things and this is just a teaser for you. But if you see a barcode sign, which means the ultrasound machine said, hey, I don't see any motion, I'm just gonna put all these white lines on here, that is a pneumothorax until proven otherwise. POCUS can detect and guide detect pleural effusions and guide thoracentesis. On ultrasound, fluid is black. Fluid is your friend. Air shows up as white lines. Air is your enemy. The ultrasound machine cannot see through air. So in this baby, you have a large pleural effusion, the black, and you have this poor little lung that is collapsed down, just flapping around and swimming in the fluid, called a squid sign. This baby was from the University of Florida when we had just started doing ultrasound. The team had a baby with acute respiratory distress. They got a chest x-ray. They see fluid on the x-ray. They place a chest tube. High fives all around. The fellow's excited. They got fluid. Didn't fix the problem. The baby is still in respiratory distress. They get another x-ray, and it looks like the fluid is still there. And so they asked us, hey, can you use that machine and see if you can tell us what's going on? And what we found, and I want to draw your attention to the right corner of the screen, what we found was this white or hyperechoic line, multiple strands in the chest, and this was a septated pleural effusion. And what they had done was place the chest tube in likely not the largest pocket of fluid. So for the next chest tube, we told them where to go, they got a lot of fluid, and the baby got better. Now, POCUS is very addictive. Once people can see it and know what's going on, they want to see it again. So we had the same team who had a baby with poor prenatal care, intubated, hypoxic ischemic encephalopathy, being cooled, born at 5 o'clock, the challenging time when all these babies tend to be born. Acidosis isn't too bad, and it seems like it's getting better, so we sent cardiology away. Don't need to do the echo today, we'll get it tomorrow. And the baby had this large pleural effusion, is how it was read. So the team said, we're not gonna do that again, where we put a chest tube into the small pocket when there's a larger pocket. Can you come and do a scan? And what we found was that there wasn't a large black pocket of fluid. It was actually a collapsed down lung pulsating in the costophrenic angle. And so when we scanned higher up, what we realized was everything in the chest looked like heart. So we quickly called the cardiologist back, said, please don't put a chest tube in there. And the baby was diagnosed with a unprenatal diagnosed Epstein's anomaly. When these kind of cases come up, and I'll show you one that especially scares me next, I just wonder, how was I able to just blindly put things in babies and not hit the heart? This baby, for those of you that don't take care of infants with congenital diaphragmatic hernias, this is a baby on ECMO, had a CDH repair. The left chest has air in it. It's supposed to be there. It's ex-vacuole. It's supposed to fill it. It's not a tension pneumo. We see this all the time. There's a chest tube to water seal. It's fine. On the right side, day after day, it's read as large pleural effusion. Day after day, we go through, should we put a chest tube in on ECMO? Should we not put the chest tube in on ECMO? I don't know why Janice, the surgeon, and I decided to do this on a weekend, but on Saturday, we said, we're done with this. We're just gonna put this chest tube in and move forward. But before we do, let's just get an ultrasound and figure out where we should put the chest tube. When we did the ultrasound, what we realized is all the way on the right side of the chest, there was again this collapsed, pulsating lung, not a large amount of fluid. When we went up to zone 1, yes, you can see we're now labeling them. We got very advanced by this stage, and we now are labeling our ultrasounds into different zones. So zone 1 is the anterior most cephalad zone, and we see the heart just beating up there on the right side of the chest. And what we realized was that this baby didn't have a large effusion, as was being read every single day. This baby actually had a tension pneumothorax. And yes, it's not supposed to happen, but it did. Had a tension pneumothorax, we relieved the tension. Janice appropriately said, I'm not putting a chest tube in the side over there when I see the heart beating there. When we spoke later to the echo tech, she said, oh yeah, it was really hard for me to find the heart. I had to find it all the way on the right side. She didn't know that was something that should be communicated with us. The cardiologists weren't communicated that fact when they read it, and it was only us doing the ultrasound that we figured it out. The next day, on Monday, the baby was doing great. We were ready to come off ECMO. My chief at the time, David Birchfield, said, what did you guys do? How did you get that fluid out on ECMO? And I got to say, funny thing, it wasn't fluid, it was the heart. So it's not just lung, although lung was my favorite and what I started with. It's also cardiac. So you can do cardiac POCUS to look for central lines, cardiac POCUS to look for massive pericardial effusions, cardiac POCUS to look for cardiac dysfunction, hypovolemia. All of these things are listed in the new document with the American Society of Echo, and yes, it's titled Targeted Neonatal Echo, but in that piece, they have recommendations and guidance for cardiac POCUS. When we're talking about cardiac POCUS, and I think some of my colleagues coming after will do a little bit more into this, what we're doing is trying to see globally what is happening. We're not looking for small, subtle things. We're looking for, is the right heart huge? Is it compressing on the left heart? Is the left heart huge? Is it barely moving? And then lastly, is there a line just flapping around in the right atrium? You can evaluate volume status. It's important to know that when we talk about volume status, we are talking about using different images, understanding your tool so that you can assess what's going on with the baby quickly at the bedside. So I want to thank Gabriel and the Neocardio Lab for some of these images. You see the apical view of the heart. We call this kissing. The endocardium is just kissing back and forth. It's underfilled. And then you go to the IVC, and the IVC is collapsed. This baby likely has hypovolemia. But don't get fooled. Hypovolemia, yes, can decrease filling of the heart, but there are other things that decrease filling of the heart. When I see a hyperdynamic LV, I think low preload, low filling. Is it volume or is it something else? And this baby it is something else. The mean airway pressure in this child was too high. The IVC was huge. It wasn't compressible. When you start scanning, you'll get used to how easy you can compress the IVC. And when you see a baby like this that has an empty heart, it leads you down a different pathway and makes you feel a little bit more confident to wean that PEEP that you've been thinking about doing all day. POCUS can also aid in evaluating abdominal concerns. This baby was concerned for free air overnight, was having emesis. A very astute and wonderful fellow, Orlin, said, I have an idea. All the surgeons were coming in, they're talking to radiology. Things got a little chaotic at night. And so she put the probe on the baby to say, I wonder what this looks like. What you're seeing is a TPNoma. It is a fluid-filled liver because of an infiltration from the UVC. Another example of using ultrasound for abdominal concerns, this baby had what was concerning for necrotizing enterocolitis. So you have absence of peristalsis, thickened bowel walls, areas that look like pneumatosis, and then you see these bright white lines. The baby had just had an x-ray. There was no free air. We were learning, so we came up and we scanned. Again, when we were learning, we thought something must be wrong with the probe. We keep seeing these white lines. The radiologist who was helping us realized that those white lines are air. This baby actually had perfed, and there was air tracking up. And so despite the fact that the x-ray didn't show it, it just wasn't enough air for the x-ray to detect. 3 pillars, not gonna go into a lot of details of this, just to say you need collaboration, you need equipment, you need quality assurance, you need structure. The National Neonatal POCUS Collaborative, we organized about 1.5 years ago. We have a website. There's lots of content there. I can share with you later the contacts, the website. I tried to make a QR code. I'm definitely not as computer savvy as other people, and especially the people that are putting on this conference, but I will work on it for next time. So take-home points. Point-of-care ultrasound, it should be done in the NICU. There's no reason not to. There has to be a defined scope, and centers need a framework in order to make this appear. So I bring you back to the case. The baby in the beginning with the subluxed knees and the wonderful, adorable family. Could point-of-care ultrasound have saved his life? And while it does no good to dwell in the past and worry about what could have been or what you could have changed, what is equally, if not more important than that, is learning from every baby and taking what you learn to teach others, not just yourself, and hopefully share their stories so that people come back from here, go back to their units and say, I can do this, we can save this baby. And for me, the answer is pretty clear. Yes, had we looked, there was a chance that we could have saved him. A huge thank you to all of my collaborators and people that have taught me along the way. I am definitely a lifelong learner and continue to have mentors throughout the country and the world. Thank you.